Good afternoon, everybody. Thanks for joining us today in our cardiology grand rounds. Welcome, Dr. Ballantyne, and thank you for joining us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderator for this event, Dr. Darío Echeverri, Director of the Cardiology Department at La Cardio. Welcome, and thank you for moderating this event.
Thank you, Lorena. Good afternoon, Dr. Ballantyne. It's an honor to have you with us as a speaker in this grand round in La Cardio, Fundación Cardioinfantil. It is an academic activity that we carry out frequently. Buenas tardes y muchas gracias a todos por su asistencia. Mi nombre es Darío Echeverri, soy el director del Departamento de Cardiología de la Fundación Cardioinfantil. Los estaré acompañando como moderador en esta conferencia. Les recordamos que al conectarse a esta conferencia autoriza el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 del 2012 y nuestra política de datos personales, la cual la pueden consultar en www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. Un agradecimiento especial a Sanofi por vincularse como patrocinador exclusivo de esta actividad. Hoy tenemos el honor de contar con la participación como expositor del doctor Christie Ballantyne por la conferencia What should we do with hyperlipidemia in individuals with high cardiovascular risk? El doctor Christie Ballantyne recibió su título de médico de Baylor College of Medicine con residencia en medicina interna en la Universidad de Texas Southwestern Medical School y se formó en cardiología en Baylor College of Medicine. Logró una beca en la American Heart Association en el Instituto Médico de Howard Hughes y el Instituto de Genética Molecular en Baylor. Es una persona experta y de renombre internacional en lípidos, aterosclerosis y prevención de enfermedades cardíacas. Ha tenido un gran interés como investigador en la prevención de enfermedades cardíacas, lo que ha permitido convertirse en un investigador consolidado desde 1988 en investigación básica de interacciones de los leucocitos y el endotelio, investigación translacional en biomarcadores y ensayos clínicos. Sus muchos logros han incluido ser elegido fellow de la Asociación Estadounidense para el Avance de la Ciencia, la Sociedad Estadounidense de Investigación Clínica y la Asociación de Médicos Estadounidenses. En el año 2012 recibió el premio al científico distinguido del American College of Cardiology. En el 2014 y 2015, Thomson Reuters reconoció al Dr. Ballantyne como una de las mentes científicas más influyentes del mundo. En el 2017 al 2020 ha sido considerado como investigador altamente citado, logrando estar entre el top del 1% de los investigadores más citados. En el 2019, el Dr. Ballantyne recibió el premio de la excelencia en investigación Michael DeBakey de Baylor College of Medicine. Su investigación en biomarcadores ha llevado a la aprobación de la FDA en 2 biomarcadores para la predicción del riesgo cardiovascular y ha desempeñado un papel destacado en el desarrollo y aprobación de la FDA de nuevas terapias para el tratamiento de lípidos. Con más de 800 publicaciones en el área de la aterosclerosis, lípidos e inflamación, el Dr. Ballantyne también forma parte del comité editorial de Circulation. Actualmente es el jefe de cardiología y jefe de investigación cardiovascular de Baylor College of Medicine y actualmente es el director de prevención de enfermedades cardiometabólicas en Baylor College. Welcome, Dr. Ballantyne. It's an honor your presentation for us.
Muchas gracias por la invitación. Pero la próxima vez me gustaría estar con ustedes en Bogotá.
Of course.
We have had a very outstanding connection of Colombian cardiologists to Houston, so we appreciate you've got a very good medical schools in Colombia, and we've had a lot of great physicians come to Houston. So I'm going to start, these are my disclosures, and I'm going to begin with a case. JC is a 65-year-old Hispanic male, history of MI and a PCI to the LAD in 2018. He's now seen a follow-up 2 months after a recent non-stemming with a PCI and a stent to the RCA at that time. And he has some disease and diagnosed circumflex, 30 to 50%, nothing that needs an intervention, but he has basically atherosclerosis in all 3 arteries. His risk factors are significant for hypertension, He's had a high cholesterol for 15 years, used to smoke tobacco, stopped after his first MI, family history of stroke in his mother at age 60, followed by a fatal MI at age 65. He's been on numerous.
Ballantyne, I'm sorry, we're not seeing your screen.
Okay, let's see. Let's go back. What happened to share screen?
Are you able to do it?
I don't see the share screen. I had share screen on. It must have been. How did it go off?
Probably because we shared the video first.
Oh, that's what happened. When you shared the video, you turned my share screen off.
Yeah, exactly.
Okay. So my topic today is what should we do with hyperlipidemia in individuals with high cardiovascular risk? These are my financial disclosures. Let's start with a case. So JC is a 65-year-old Hispanic male, history of MI and PCI to the LAD in 2018.
Sorry, Dr. Ballantyne, we still don't see your screen.
You know, you have to turn yours off then. Are you not sharing?
No, I'm not sharing my screen. Nobody's sharing the screen. So let me, 1 second.
I'm on share screen.
1 second. I'm gonna, oh, now I can see your screen. Perfect. There it is. Thank you so much. I'm sorry.
So my topic today is what should we do with hyperlipidemia in individuals with high cardiovascular risk? These are my disclosures. Let's start with a case. JC is a 65-year-old Hispanic male, history of MI and PCI to the LAD in 2018. He's now seen in follow-up 2 months after another recent STEMI. Non-STEMI with PCI is sent to the RCA. His cath also showed 30 to 50% lesions in diagonal and circumflex, so he has some disease in all 3 arteries, major arteries. Risk factors: hypertension, high cholesterol for 15 years, smoked in the past, stopped after his first MI. Family history of stroke in his mother at age 60. She had a subsequent fatal MI at age 65. He's been on numerous statins, including atorvastatin 40 milligrams, which led to complaints of severe muscle pain and weakness 4 months ago. He was switched to rosuvastatin 10 milligrams. He's been taking the 10 milligrams plus ezetimibe, and now he complains of sore muscles, but denies any weakness. His blood pressure is 135/85. His height is 5'8". He weighs 170 pounds. His BMI is 23.1. On exam, he doesn't have corneal arcus or xanthomas or xanthelasma. He does have a right femoral bruit and a decreased right dorsalis pedis and posterior tibial pulse. He's on 3 medicines for blood pressure. He's on 2 medicines for his lipids, rosuvastatin and ezetimibe. He's on aspirin and ticagrelor. His lipid profile shows a total cholesterol of 190, triglycerides of 130, HDL is 38, LDL is 80. His glucose is 115, EGFR 65, CK is slightly elevated in this individual. His HSCRP is 2.2. So based upon his risk status, which of the following answers is most consistent with your views about his LDL cholesterol? The LDL target should be less than 70. The LDL target should be less than 55. Should be less than 40. There is no LDL target and should be placed on 40 milligrams of rosuvastatin. You don't need the ezetimibe. Or his LDL cholesterol is above the threshold to consider the addition of an LDL cholesterol lowering therapy for a very high-risk individual with ASCVD. Now, this question is not so straightforward because there are different guidelines in different parts of the world. Let's go with the most recent US guidelines. And they had a very important change in these guidelines, is that we used to think of just primary and secondary prevention. And now we have a very high risk category. And we'll talk about who these are, but you would certainly think someone with a recent ACS with a risk factor that we described would probably be in this category. In this group, needs high intensity maximal statins. We now have an LDL threshold. If they're over 70, then we need to consider adding a second agent. And this patient's already on ezetimibe and a statin over 70, and basically was the addition of PCSK9 inhibitor was a reasonable choice for this kind of a patient. Now, we'll go into some more details of this. First of all, what is the definition of a very high-risk individual? Well, so we have a threshold. We're trying to get our LDLs. If it's over 70, we'd like to lower that much more. We'll talk about the evidence. Who are these individuals? Someone who's had a major ASCVD event, so a recent ACS, certainly puts you in a high risk, a history of an MI, history of ischemic stroke, symptomatic peripheral arterial disease. What are the other conditions? If someone has a history of prior CABG or PCI, this person had a prior PCI, person has hypertension, they used to smoke, they have a BRUI, so they have some peripheral arterial disease. Over half of your patients who have had a clinical cardiovascular disease fall into the very high risk category. So that's important. These are very common patients in your practice. Now, the European guidelines are somewhat different. They have a very high risk category. Theirs is a little bit simpler. It said anybody with clinical ASCVD or imaging showing ASCVD, they have a different scoring system. We use the Poole-Court equation. They use the score if it's over 10%. They also have diabetes with target organ damage and 3 major risk factors, and also CKD with an EGFR less than 30. That's their very high risk, which is broader than the ACC one. They have a target to get to less than 55 milligrams or lower with it. So there are some differences in terms of these guidelines. So everyone says use a high intensity statin first, reduce LDL 50%. You'd like to get to less than 50. So in all of the guidelines, what do we see is they all agree that atherogenic lipoproteins play a causal role in the development, the progression, and also atherothrombotic clinical events. The target of therapy is to lower atherogenic lipoproteins, and the most important thing that we measure is LDL cholesterol. So it's very important that you measure LDL cholesterol. That's in all of the guidelines. After you have treated somebody, you have to measure LDL cholesterol to see where have you been successful? Have you treated the patient optimally? So why did the guidelines change? Evidence from non-statins being added to statins. So this was adding ezetimibe. Ezetimibe, as you know, gives a somewhat modest reduction in LDL cholesterol. This was in the IMPROVE-IT study. LDLs were 70. They went down to 54. There was a significant relative risk reduction in total events. It was actually a greater risk reduction in the very high-risk patients. Another trial was done where ezetimibe was used in individuals. This was a Japanese study with much higher LDLs. They looked at ezetimibe in older individuals. It was a probe design, and there was a benefit in regards to reducing events. So we have some data that ezetimibe added to statins, which lowers LDL more, gives further event reduction. There was also another stroke trial where they did the strategy of adding more intensive therapy. Now, we had a tremendous program developing PCSK9 inhibitors. And this was, I've been in this field now for a few decades. And it was really exciting because I trained in genetics, as was mentioned. So in 2003, a family in France was noted to have what appeared to be familial hypercholesterolemia, but it was not a mutation in the LDL receptor. It was a mutation in PCSK9, a gain of function mutation. Now, we're the core laboratory for the ERIC study. And it turns out that in collaboration with the people in the Dallas Heart study, Helen Hobbs and Jonathan Cohen, this was looked at in the ERIC study. There were lots of function mutations, lower LDLs, less heart disease risk, and now you're off to the races, because with biotechnology, one can create monoclonal antibodies, and within, it's a really remarkable. So when this proof of concept in 2006, the first approval for use in humans was in 2015, less than a decade, faster than we've ever seen any program develop. But that wasn't the end of it, is that after approval, we had the Glagov study, we've had Odyssey Outcomes, a Fourier study, and there's more in the pipeline in regards to a high-risk primary prevention study, and data showing the safety of using one of these agents immediately in the post-ACS period. So the first one was the Glagov study. People with stable coronary disease, about 1,000 patients. I was on the steering committee for this trial. And what was seen was if you treated these individuals intensively, lowering LDLs down into the 30s, is that there was more regression of atherosclerosis, less progression, and basically the lower the LDL, it appeared, the greater the benefit. Fourier study. This was another trial in which patients came in with an LDL over 70. They had atherosclerotic clinical disease plus other risk factors, so they were high-risk patients. LDL was reduced by 59%. There was a relative risk reduction of 15%, and of CV death, MI, and stroke, 20%. Now, if we look, that's time to first event. If you look at time to total events, what you see is greater benefit. We're not only concerned in a clinical trial, look at the time to first event, but when we treat our patients, we're concerned about the total events. And this was a very short duration study. This was a median duration of less than 2.5 years. The lower the LDL, the greater the benefit. And this was also seen in people who had LDLs less than 70 in this trial. And there was safety across the board. In the study, we didn't see any major things. Now, Odyssey Outcome, patients who've had a recent event, once again, now we see that there was a benefit of 15% of relative risk reduction. We saw tremendous safety in this study. And in addition to this, there was some patients who got into this trial who actually were not on statins. It was on maximum tolerated statins. They had the highest LDL. They had great benefit. In fact, even in that small group, there was a reduction in mortality. Now, what did we see from Odyssey Outcomes? What did we see from the study that was done? A summary from Fourier is we have a consistent finding. And I think as clinicians who are treating patients with coronary artery disease, if we were to think of who are the patients who have the greatest burden of atherosclerosis, well, we've known for many decades, going back to the early work that was done with Soanes at the Cleveland Clinic, if you've got 3-vessel coronary disease, you have a much worse outcome. People who have a high burden of atherosclerosis, so you've got peripheral arterial disease, carotid disease, and coronary disease, you have a much worse prognosis. And if you have had an MI and you have diabetes, we know that there's more diffuse endothelial dysfunction and atherosclerosis everywhere. Now, not only is the burden of atherosclerosis important, but the activity of atherosclerosis. A recent ACS, as I mentioned, patients with diabetes not only having more disease, but more progression disease, high CRP, high LPA. Another important factor was individuals with high LPA had greater benefit from PCSK9 inhibitors, and also a high polygenic risk score. Now, that's not something that most of you are probably ordering on your patients, but all these other clinical factors are really key in regards to saying, which of my patients is most likely to go on to have another event? And these are the patients that make sense who are going to have the greatest benefit from treatment. And that has been shown consistently in these studies. When we look at subgroup analyses from both trials, you put them together, is there was a greater benefit in this patient population. And you know, the other one is if someone has a persistently high LDL, for example, an Odyssey outcome, there was a benefit in mortality in that patient group. Okay, now what's happening in practice? Well, we've been involved with the Gould Registry, and it's interesting. This was a survey of the physicians. Most of the physicians believe you should get to LDL less than 50. That would be optimal. And that's what these studies showed. Getting LDLs to very low levels would be, the beneficial. But in fact, that's not what's happening in clinical practice. So in the Gould Registry, if people have had an MI within a year, about 62% were on high intensity statin, 8.5% on ezetimibe, 3.1% in PCSK9 inhibitors. Now, if you go to Sweden, which is a nationalized system, they've done a great job with high intensity statins. 87% were on high intensity statins, but almost no use of combination therapy. Ezetimibe 3%, PCSK9 inhibitor 0.02%. And that was because of difficulty with access. So it's interesting. In the Gould Registry, we've looked at treatment of hypertension. And the same physicians who are using very little combination therapy for lipids, 70% of the patients are on combination therapy for hypertension. So we all know that if you want to be effective for treating blood pressure, use of combination therapy is really an important aspect of this. Yet we don't take the same approach with lipids. Okay, so let's go back to our patient in terms of his situation. So we mentioned he had a prior MI in PCI, comes in now with a non-STEMI with PCI, and it's got a stent. So he's had a second event. He's what we might call a frequent flyer, hypertension, family history, used to smoke, has had difficulty, is on maximally tolerated statin and ezetimibe, and his LDL was over, was 80. So what does he have? He's got 3 vessel coronary disease, the things we mentioned. He's got peripheral arterial disease on physical exam, a bruit and decreased pulses in his right leg. Had a recent ACS. His HSCRP was over 2. So this patient is a very high risk patient. And so even though he's on a combination therapy, his LDL is really not sufficiently well treated in terms of the optimum for reducing his risk. So I think one of the important parts of our guideline is this concept of joint decision making. And so when we discuss risk of the patient, that's important. What is his risk for a future event? And when we talk about therapies, though, he has concerns about, well, what are the risks of the therapy? What are the benefits of the therapy? These are important issues that we need to go through with our patients. So this was, I'm showing the data out of Fourier. It's the same out of Odyssey Outcome, but basically, if we look at the PCSK9 inhibitors, these are fully human monoclonal antibodies. The only adverse effect that we saw in these trials was some local injection site reactions as compared to placebo. No impact on glucose. I mean, this is a remarkable safety profile that has been seen with both of these agents. There's no impact on cognitive, despite getting to very low levels of LDL cholesterol. What are the benefits? Okay, so the benefits that we have seen with these agents is that, first of all, you're going to have enhanced regression of atherosclerosis. I think that's something that if somebody has had 2 events and they've got disease in other arteries, they would like to see that this would be beneficial for that. You can not only reduce MI, you reduce stroke, you reduce hospitalizations for angina, you reduce the need for revascularization here. And the benefit is greatest in those people who've had recent MI, 3 vessel disease, PAD, or diabetes. So this patient, if we ask about what are his concerns, he doesn't want to have a stroke, die like his mother. He didn't want to have another MI, didn't want to have another event. So he's interested. one of the key issues, if you're going to start a PCSK9 inhibitor, some people have fears of injection. Now, if someone's diabetic using insulin, this is much less of an issue. But we like to have the patient, and we demonstrate in the clinic how to do the injections. It reduces the anxiety and the fear of the injection. And a lot of times we will give the first injection in the clinic. We're fortunate that we frequently have a sample available, but they also have some of the pens. You can just show the patient how to do this. There's also YouTube videos that people can watch about doing that. We like to repeat the lab test on someone just before the third or fourth injection. And frequently the LDL cholesterol comes back very low. The important thing is to reassure the patient that's what we want. We want it to be low. And if necessary, in a case like this, if the LDL were to, let's say, to be 10. Now, first of all, the Friedewald equation doesn't work as well with low LDL cholesterols, but you do have the option here. If it got down to a very low level, the ezetimibe could be stopped. I would keep the patient on the statin, but if you've used a PCSK9 inhibitor with a statin and they get to an extremely low level of LDL, then there may be no need to continue the ezetimibe. Okay, a couple of challenges, and there's some new things that are going on. What are some other things in terms of these difficult to treat patients? All right, so one of them is bempidoic acid. This is an oral agent. What does it do? It inhibits ATP citrate lyase. That's upstream of statins. So it's the same pathway as a statin. It's eliminated in the kidney, and it's an O2 transporter. Well, that's important because it can increase uric acid in some patients. We know from genetic studies that at least in Mendelian randomization, people with genetic variants in this, that lower LDL have some reduction in events. It appears to be similar to that we see for the amount of LDL for HMG co-reductase and NPC1L1, and it appears to be additive. So it's a nice proof of concept. Now, in terms of the LDL reduction, when you add this to someone who is on a maximally tolerated statin therapy in Clear Harmony and Clear Wisdom, what you see is a reduction of about 18 to 17%. So you get further reduction. Now, obviously, this is not in the range when I mentioned it with a PCSK9 inhibitor, you're seeing a 60% further reduction on top of maximal intensity statin. Now, what is a little different, if someone is unable to tolerate a statin, what we see is more efficacy. Placebo subtracted differences here were 28 and 21%, but more efficacy because it's in the same pathway as a statin. It is available as a combination tablet, so this would be an oral option, giving around 38% reduction in LDL cholesterol. I mentioned hyperuricemia, and this is particularly a problem of gout if someone has a history of gout or a high level of uric acid that was seen with it. And there is an outcomes trial in progress. It's called Clear Outcomes, double-blind study, fully enrolled of people who are statin intolerant. So we'll get more information about this in the next few years. Now, there's a novel approach. PCSK9 is a very attractive target. And a novel approach, the world is mRNA therapeutics with the vaccines. This, instead of overproducing, what you're doing is you're knocking down mRNA expression for PCSK9. Inclisiran was approved in Europe, not approved by the FDA at this time. Sub-Q injection, followed by dosing at 3 months and then every 6 months. Very interesting molecule and interesting data that the Orion program has been done. This was submitted to the FDA, their phase 3 trials, and they're very consistent. What ends up happening is you give the first injection in 3 months and every 6 months, and you're lowering LDL in general around 50%. The safety looked good. There are some injection site reactions, but there was not a liver, which was one of the concerns that we had with a drug that has a long biological activity every 6 months. This was the Orion 10 results, very similar, and there's a large outcomes trial that is in progress for this agent. So this is an interesting, one of our problems is adherence. So that's where they're, having more options may help with that. Bempidoic acid and inclisiran. And where we actually, and this is something that we look at when you take a statin, you take a medicine every day. Now with the monoclonals, it's 26 injections in a year. It's every 2 weeks, and you can do this once a month, so it's 12 a year. And one thing that was very interesting is that I was very surprised at how much are the acceptance when someone, after they've taken this a few times, these injections are quite easy and patients do very well. And in fact, we've seen as good adherence in our clinic. In fact, sometimes better than taking a pill every day. Now the siRNAs, that's 2 injections a year. Vaccinations, if they work, might just be very infrequent. And now gene editing with CRISPR, maybe once in a lifetime. So lots of technologies that may make an impact. I'm going to finish up with just some comments on triglycerides. As you're aware, we have in the United States consideration of very high is over 500. Over 150 is considered to be somewhat elevated. 200 is going to be considered to be elevated. In the past, our focus was on LDL and HDL, but genetics, when we looked at genetic variants, we have seen that it's very consistent for LDL. Is the genes that make an impact on raising LDL, increased risk for heart disease, same thing if they go lower. It turns out that this was also seen for triglycerides. Now you had to have a bigger impact, basically a 90 milligram per deciliter change in triglycerides gives you about the same as a 35 milligrams deciliter change in LDL. But we did not see this for HDL. So we have much more interest in triglycerides. And we've known in the past that even if you got LDLs to less than 70, people with high triglycerides have some increase in risk. This was from the Prove It study done a number of years ago. Why do they have a high risk? Well, this is really, there's all kinds of things. They have small dense LDL, they have low HDL, there's ApoC3 increase. There's also inflammation increase. A lot of work ongoing to understand the risk. It's also obesity and diabetes, metabolic syndrome. What do we do about it? Well, there was a study a number of years ago done in Japan called the JELIS trial where they used EPA. It was a probe design, so prospective randomized open label blinded endpoints showed a benefit, but these people were on low dose statin. They had pretty high LDLs. They weren't treated that well. The group that had the greatest benefit were people who had metabolic syndrome and elevated triglycerides. A small company approached me a number of years ago to do a trial in high-risk individuals with elevated triglycerides on statin therapy to see what would be the benefit of EPA in regards to their lipids. And we saw that EPA did reduce triglycerides, modestly reduced non-HDL cholesterol, and with a modest reduction in ApoB, and did not raise LDL cholesterol. Well, based upon this, they decided to do an outcome study, which I thought was rather bold. And this was led by DeBakey. I was a senior author on this publication in New England Journal of Medicine. And it was, to be honest with you, quite surprising to see a very robust reduction in this study, which was designed to be rather than just a Japanese study, it was a multi-center trial, international study. And to enrich the patient population, they had a high triglycerides, cardiovascular disease, primarily along with some people with diabetes and increased risk. So significant reductions in both the primary and secondary endpoints. I was also a member of a steering committee of another trial called the Strength Study. And this used a mixture. Instead of using EPA, it was a mixture of EPA and DHA, and it was a different formulation of carboxylic acid rather than an ethyl ester. It was disappointing. It was stopped early due to futility. And as you can see, it was indeed futile. There was no difference between the active therapy of the omega-3 mixture of EPA and DHA and corn oil. So what are the similarities and what are the differences? Well, as you can see, Reduce It had more secondary prevention, a little bit more men with it, less high intensity statins. Triglycerides were actually a little higher in strength. LDL was the same. Now, the active treatments were different. One was icosapent ethyl, 2 grams twice daily. It's a pure EPA mixture versus a mixture of EPA and DHA in the capsules. There's a difference in placebo. There's a mineral oil placebo. There's problems with the capsule. If you use water, you can tell the difference between water in a capsule versus an oil. So this was mineral oil. The other one was corn oil. And there's discussions about mineral oil may have some adverse effects. Corn oil may have some beneficial effects. There was a much longer duration in the Reduce It study, 4.9 versus 3.5 years. Was also the strength included a hospitalization for unstable angina. That was not a major driver. This was Reduce It was longer. There was a higher event rate. There was also a higher level of EPA achieved. It went up almost fourfold in this study, in Reduce It versus the strength study. All right, now, I've also been an author, and my colleague at Baylor, Salim Varani, was a lead author of a study, an ACC expert consensus decision pathway. What about the patient who has elevated triglycerides? What do we do with that patient? I'm just going to focus on the patients with ASCVD who have a high triglyceride, fasting over greater than equal to 150. So, but less than 500. Now, if they're over 500, there's a bit of a different approach. First thing you have to look at in these patients is secondary causes. Diabetes, alcohol, diet, and lifestyle are extremely important for high triglycerides. The other thing is, don't forget, high intensity statins lower triglycerides. So it's very important these people be on high intensity statins. It's very important to achieve glucose control. And if you've done that, and then they continue to have high triglycerides, the other thing is a nutritional consult and discussing more on exercise. And weight loss is extremely important in these individuals. So this was a summary about some of the aspects. It's important to get a very good history, secondary causes in terms of medications that might have been also playing a role here. And then you need to look on the exam, the body weight, the diet, carbohydrates in the diet, alcohol, very important with this. Do they eat cold water, fish in the diet? That may be beneficial. What's the physical activity level of the individuals? And if we take a look at the diet, we want to have people on low carbohydrates, especially simple sugars. You don't want any, you'd like to have added sugars really minimized. If you have a very high triglyceride over 1,000, you need to really be much stricter in both to the carbohydrates and the fat, and you should stop alcohol completely. In the lower levels, it's an issue of drinking moderately, no more than 2 drinks per day, ideally 1. And physical activity is extremely important in these patients, and also weight loss is extremely important in a patient with high triglycerides. If you can make these changes in lifestyle and use high intensity statin, you will very frequently have excellent results. All right, now what if you don't? So what if they still remain up here? Well, one of the things, that's to go through the thing, we talked about secondary causes, diet and lifestyle, glycemic control. So if the LDL is still high, maximize statin therapy, and then also go on the LDL pathway, which we talked about here in these patients. We're talking about non-statins to lower LDL and what's in the guidelines, ezetimibe, PCSK9 inhibitors. If the LDL is over 70, once again, look at the patient. You can discuss the patients there. We know the LDL-based risk approach is beneficial in these patients. These people were in the Odyssey Outcomes study. They were also in the Fourier study and Improve It. So there's a benefit for further LDL reductions. Now, you can also look at the triglyceride-based approach in these people. Once again, is lifestyle been optimized? Did you do as much as you possible? Because that may lower triglycerides further. And then one might consider icosapent ethyl. We do not have the data of the benefits for the mixtures of EPA and DHA, and also for the supplements. There are no studies to show benefit. Okay, let's summarize it and wrap up. So it's very important that your patients, you look at their risk category. Very high risk individuals benefit from intensive LDL cholesterol lowering therapy. So high intensity statin, maximally tolerated statin, unfortunately, that may sometimes be zero. If you should always try 2 or 3 statins, but some people don't tolerate it. And we always go to even every other day low dose statins. If it's over 70 at this point, then initiate non-statin therapy. And my personal goal, you want to really reduce their LDL substantially to reduce their risk. We've got the data from ezetimibe and PCSK9 monoclonal antibodies that these agents will reduce events. We have some newer agents as potential options. We do not have outcomes on either one of these, and inclisiran is still not approved by the FDA. It's only available by the EMA. What about triglycerides? Well, when we see high triglycerides, it's a risk marker. We've got lots of data about this. We don't have lots of treatments. We know statins work. We know that LDL lowering works, as I said, in the trials that were done with the PCSK9 inhibitors and ezetimibe, there is a benefit of LDL lowering in these patients. We have one study, the REDUCE study, that showed high dose EPA had benefit in these studies. We did not see this with the string study. And there is an ACC. Lifestyle is very important in these patients. Control of diabetes, other risk factors, exercise, low carbohydrate, reduced saturated fat. And there's an expert ACC consensus pathway, not a guideline, just a pathway to help guide some of the processes in this for both lifestyle and how you guide through in terms of using medications. With that, I'm going to stop it and I'll open this up if there's any questions or comments about the things that I covered. Thank you very much.
Thank you, Dr. Ballantyne. It's an excellent presentation and very useful. So I enjoy a lot your presentation. I have many questions, but I want to begin with the first, which is the best risk score for clinicians useful in our population. For example, in Latin America, we have many population came from Venezuela, the migrants, and now we are looking more patients with younger people and older people.
Yeah.
How we use the score in these populations?
So this is a very good question, because what ends up happening is we use the Poole-Court equation in the United States, but the Poole-Court equation, even in the United States, does not work equally well in all populations. I live in Houston. So Houston is we're very, I think it's the most ethnically mixed city in the United States. So we have big Hispanic population, East Asian, South Asian, African American, and there's also there's a lot of heart disease. I looked at something in Northern California in the Kaiser. Now Northern California, partly a little more health conscious. They're more into the outdoors and lifestyle and these types of things. The Poole-Court equation over predicted risk in that population. It does pretty well in our population, but it doesn't do the same. And that's why the score one in Europe is different between the northern countries and the Mediterranean countries. So I think you have a very good point, is if we look in, Latin America and in different countries, it's really somewhat challenging to know for sure. And as you said, you've got a mixture in any individual company, people in different areas of the country. And then also other things do make a thing in terms of what is their education, their lifestyle, their habits. So this is something where I do think in the most recent guidelines, they talk about coronary artery calcium scoring. And I don't know how inexpensive that is. In the United States, it turned out that this has gotten to be a fairly inexpensive test. You get a CT and look at the coronary artery calcium score. It's about $130 in Houston, and other places it's $100, but it gives you tremendous amount of data in terms of what is the actual risk, because unfortunately, the PCE may overestimate, underestimate. What do you do about family history in these individuals? So it's a very tough question. Ultrasound, it has limitations. You need to be probably 40 years or older, and for women even maybe 50, because in younger people it's a 0, doesn't tell you much. The other, some people will use is ultrasound. Fuster's done a lot with this, of looking at the carotids and the femorals. So is it thick or do you have plaque? So the presence of disease by CT, we call it coronary calcium score, or by ultrasound, does shift someone into a higher risk category, and it gives you a little firmer evidence for this. But it is something where I think we need a lot of work to come up with specific countries to help people in terms of risk assessment. And it'll be an area where there'll be a lot of improvements, I think, in the coming years.
Okay. In Colombia, in a special center, the Javeriana University people validate for Colombian population the Framingham score. It's the only one study in Colombia that we recommended today is the Framingham, and this is a validate. And another question is in general, our objectives is the plaque prevention and plaque stabilization, okay? And more in high-risk population. But why are the LDL cholesterol goals different in individuals with high, intermediate, or low risk, cardiovascular risk? Because our objectives is reduce the plaque. And why is more important in high risk the level below the 70% or 70 milligrams versus in the low risk population we accept more than 100%.
So this is a very, very good question and important point, is that basically it has to do with the benefits of therapy and the risks of therapy. So there is a benefit in everybody of getting LDL, I think, to very low levels. The issue is if you have no plaque and you're 75 years old and you don't have any plaque in your arteries, do we really need to get your LDL down to 40? Do you see what I'm saying? There are people who won't get much benefit by aggressive treatment. Whereas we know that, and there's also the cost of the treatment and maybe side effects of treatment. However, you bring up a very important point, is that let's say someone has a very bad family history. Wouldn't they benefit from starting a statin earlier and getting their LDL very low before they have clinical disease? And I agree with you. So, I think where we have is, my personal philosophy on prevention is, our biggest problem is that we do too little, too late in life. We don't treat blood pressure aggressively. We don't treat lipids aggressively. People don't get motivated with their lifestyle. And then someone has an event, at which point, as you said, now we have usually quite a bit of disease everywhere. It's very late, and we say, oh, now we got to do something. So, what I liken this to, it's like, in cardiologists, for the most part, we are more like firemen. The fire is going on and you go rescue somebody and they're having a STEMI and you go in, or then we put an LVAD or a heart transplant. So it's heroic, But if you take a look, you actually get more benefit from just having smoke detectors in well-designed places, and so that you don't ever get the fire. You're right. If you design a building well, you have less fires, and it gets picked up with a smoke alarm. You never need to have the sirens and rescue somebody out. So we should be doing this, I think, with it. But but that's an approach of really, working with pediatrics, family practice doctors, primary care doctors. I think we should be doing a much better job on some simple things, blood pressure, lipids, and starting earlier, because if you started earlier, you might not have to be so aggressive later. I think you're on mute. Sorry.
Yes, I'm sorry. We are in today in cardiology, and a very beautiful time for prevention, imaging, structural heart disease, surgery, interventions, gene therapy, etc. I think we are lucky to see this moment, but we need to rationalize the procedures, the medications, the new medications. More in our countries, the costs. And according to the imaging, you recommend the imaging in which people for cardiovascular risk complementary, for example, intermediate risk or high risk for confirm the disease?
In general, I think if they're a high risk, certainly if you're okay to be, I think the benefits are greater than the risk of the treatment. Treatments, certainly if it's statin, the risk profile is very low on statins. So some of this has to do with that patient-physician discussion. If somebody sees me, and let's say I do the Framingham score and their risk is still low, but they have a very bad family history, and I'm concerned about them, and maybe I measure lipoprotein A and it's high. Well, I start them on a statin early in life with it, even if their risk is low. So if they end up being, well, I don't want to take a statin. Do I really have to take a statin? And so maybe they're 45 years old and they're intermediate risk. So then I do an imaging test, and it's more to persuade that person, look, you have a calcium score that's 98 percentile. When they see that, they say, okay, I guess I inherited this from my mother or father. I better start now. Now, if they have a 0, I have to warn them, this doesn't mean you're protected lifelong. You're going to be in good shape for the next 5 years, but you're only 45 years old. We're worried about the next 30 years. So I still need you to try to work on your diet, your exercise, your blood pressure with it. But it can be a useful thing for risk, when you're particularly in that intermediate category. That's where I think it can make the biggest impact.
Okay, perfect. And finally, the last 2 questions. In your practice, you identify the high-risk people with high cholesterol. You use the high-intensity statins as atorvastatin or rosuvastatin, and you wait how many long for decide to use the PCSK9 inhibitors?
So you will see all of your impact within 4 weeks, and you get 90% of your reduction in 2 weeks. Okay. So you don't have to wait very long.
Okay. And finally, my last question. Exists around the statins therapy some myths or some mysteries about the effect the statins in coronary calcifications, the effects in diabetics, the effects in hormones as estrogen or androgens. Which is your any comments about the?
So the stats, if someone has high calcium and they go on a statin, I usually don't try to repeat the study because calcium is going to get worse. It progresses in people anyway, but we don't think that's, we know it reduces the event. So it may end up being is that, you know, the actual areas where you have higher calcium scores are not where you're having the plaque ruptures. It's really usually in the soft plaque. In terms of diabetes, there is a slight increase to progress from pre-diabetes to diabetes. I use this as an opportunity to talk to people about the diabetes prevention program. If someone will start exercising, on that program they were doing 30 minutes, 6 days a week, 3 hours a week of walking, lose 5 to 7% of body weight. They reduce diabetes by 2/3. And when I tell people that, they say, can you do this? We could reduce your chance for diabetes by 2/3 with your just some exercising and some modest weight loss. They say, well, I think I can do that. Because what will happen is that will be a much better impact than a small increase. The statins increase glucose a little bit in those people. They still reduce events, and it's beneficial. You know, the data on hormones is pretty clear that there's not a major effect on hormones in terms of individuals with it. There is the issue of treating premenopausal women in terms of, you know, statins and pregnancy, where we still try to avoid that. They're probably safer than we thought, but they're still, and they've changed some of the labeling about it just recently in the United States, but in general, we avoid statins during pregnancy.
Okay. And I'm thinking in the last question again. Now, which is the effect, the exercise or the diet for reduce the risk, the cardiovascular risk?
So they both have benefits. In terms of losing weight, diet is essential because you can out eat your exercise, but exercise has other benefits in regards to, I think, the endothelium, your vasculature. And we do see people who are, even though they're overweight, they're much more healthy overweight with it. So I think both are important. And one thing that I would emphasize, and I see this as I've gotten older, is this whole concept of prevention and really not just disease, but healthy aging. And what we see is that as you get older, you know, frailty becomes one of the biggest problems. People having falls, injuring themselves, but also exercise is one of the most strongest associations with basically people who don't have the decline in cognition. So, you know, if you talk to an older person, the last thing you want someone to do is start falling down, breaking bones, end up, you know, they lose their muscle mass, they become frail, and then they, you know, lose their cognitive ability. So exercise is really fundamental for healthy aging.
Yeah, it's a fundamental one, but reduce the risk score, reduce the plaque, the burden plaque.
So it's going to end up it'll be more on the blood pressure side, exercise, rather than on the endothelial function side. On terms of, and it'll make triglycerides go down. It does not reduce cholesterol very well. So if you want to lower cholesterol, you end up having to use medications. You can prevent diabetes, you can help some blood pressure effects, but you know, if someone has genetic high cholesterol, you can exercise all you want. I mean, it'll get worse if you eat bad, but you cannot improve it with exercise. So you have to do something else. Okay.
Okay. Thank you very much, Dr. Ballantyne. It's a pleasure for us. We learn a lot. We enjoy and waiting for you here in Colombia. This is your home. Quiero darle las gracias al Dr. Ballantyne por acompañarnos. Muchas gracias a todos los participantes por su asistencia. Y nuevamente gracias a Sanofi por su apoyo, por el desarrollo de esta conferencia y hasta una próxima oportunidad. Dr. Ballantyne, bye-bye.
Muchas gracias.